All right, if you guys thought fluids, electrolytes, and nutrition was fun in 90 minutes, just wait for critical care. This is critical care in 90 minutes. I have no conflicts of interest to disclose. So here's our agenda. It's a light agenda. So we're going to talk about sepsis-related stuff. We're going to talk about hemodynamics. I'm hopefully going to show you that it's not so scary. We'll talk about initial resuscitation, what to do in those first few hours, some definitions of sepsis, vasopressors. We'll talk about antibiotics, how to use them, when to give them, what to do, and corticosteroids. And mixed in with this, I'll give you a little bit of a history of what's happened over the last couple of decades in critical care, which unfortunately I've been around for. Other critical care issues, we'll talk about hypothermia, which is now called targeted temperature management, TTM, and cardiac arrest in those patients. We'll talk about analgesia and sedation issues, delirium, hyperglycemia, which has literally been we're back to square one over the last 10 to 20 years. We've started being very aggressive, and now we've kind of come back to being less aggressive with hyperglycemia. We'll talk about stress ulcer, a little bit about DVT prophylaxis, very, very little. Prevention of ventilator-associated pneumonia, and just a little bit more on nutrition as it relates primarily to critically ill patients. So I'm going to start off with hemodynamics, and I've separated these into indicators of volume and indicators of heart function and oxygen use and things. So we're going to start off with indicators of volume. And this is physics. So pressure is an indication of volume. As you increase your volume, you increase your pressure. So we're going to start off with mean arterial pressure. And the equation is right here. The equation for it is you take your diastolic pressure and then you add a third of the difference between your systolic and diastolic. This is an indication of global perfusion pressure. It's better than your systolic over your diastolic, just your regular blood pressure, because this is more of a global perfusion. How are you perfusing your body? A mean arterial pressure greater than 60 is needed to perfuse your organs. It's mostly dependent, if you look at that equation, it's mostly dependent on diastolic blood pressure. Why is that, do you think? During diastole is when your heart is resting, but it's also when your heart perfuses itself. So you have coronary perfusion during diastole. And so this mean arterial pressure, it's a real important number and heavily based on diastolic blood pressure. Now there's your central venous pressure. This is the pressure in your thoracic vena cava near your right atrium. So you put in a venous line and you have a transducer on the end of it and you can assess the pressure. Still the same concept as mean arterial pressure or blood pressure, but it's just a different location. And it reflects the preload or your intravascular volume. And your heart functions, or your cardiac output, it functions optimally at a central venous pressure of around 8 to 12 millimeters of mercury. So now let's think about indicators of blood flow and heart function. First is your cardiac output. It's the amount of blood pumped per minute. Normally it's 4 to 8 liters per minute, but it depends on your body size. So we can't really compare cardiac output from one person to another if they're different body sizes. So for that reason, we prefer to use cardiac index, which is your cardiac output standardized to your body surface area. It's very easy to do. A normal cardiac index is between 2.5 to 4 liters per minute, and that's for everybody in this room, regardless of your body size. Now, those are indicators of blood flow. But your central venous pressure and also your pulmonary capillary wedge pressure, which is just another pressure, just a different location, don't get scared about it, described in your book, these can indicate heart function as well. because as you have forward flow, as you have that cardiac output, if your forward flow is impaired, then you'll see an increase in volume and thus an increase in pressure. Those will increase. So your CVP and your wedge pressure can be increased, and that can be an indication not that you have too much volume in your whole body, but that your heart function is a little bit sluggish. So these can indicate heart function as well as intravascular volume. How about indicators of oxygen transport and use? One is lactic acid. You know, when you go to the gym, we all go to the gym, right? When you go to the gym and you're working out and you feel that burn, that's because your muscles are undergoing anaerobic metabolism. So when you have oxygen, you don't undergo anaerobic metabolism. If you have a decrease in oxygen, if you have a decrease in perfusion to your tissues, then your tissues undergo anaerobic metabolism, and the byproduct is lactic acid. So lactic acid is an indication of a lack of oxygen to your tissues, lack of oxygen transported to your tissues. Also, your venous saturation, or SVO2, okay? It sounds scary, but again, it's not. This also can indicate oxygen transport and use. So why is this? Your arterial oxygen saturation, your arteries, right? That's right out of your lungs. You breathe in your oxygen, and then your arterial saturation should be right around 98 to 100%. Okay, high saturation with oxygen. And then, as it goes through your heart, and you dish out a little oxygen, here's some for your heart, oh, here's some for your brain, you go through the rest of your body, and you dish out your oxygen to all of your organs. And then, when it comes back on the venous side, your oxygen saturation, your venous saturation, is around 70 to 75%. Okay, which means it's about a 25% oxygen extraction ratio. You use about 25% from the arterial side over to the venous side on average. Some organs take a little more than that, some take a little bit less, right? So during hypoperfusion, the extraction ratio is bigger because your tissues, as your blood comes by, if it's coming by a little bit slower because your heart's not working as efficiently or your metabolic demand is increased, if they're not getting enough oxygen, your tissues are saying, oh, well, it's not coming by as fast as I need it. I'm taking a little bit more. And so your venous saturation is going to be lower, okay, because of that increase in tissue demand or a decrease in the supply. So a low venous saturation, despite fluid resuscitation, could be a sign that you've filled up your tank, but your cardiac output is still just not quite enough for your demand. So it could be a sign of an insufficient cardiac output based on the demand. It doesn't necessarily mean that they have heart failure, because it could be just a patient that can't meet their demands of their illness. So how about indicators of vascular tone? We have a systemic vascular resistance. This is a calculated number. It's not measured like blood pressure or central venous pressure or cardiac output. We can measure cardiac output. Systemic vascular resistance can be used as a diagnostic tool to say, looks like this patient might have sepsis if they have a very low systemic vascular resistance. But it doesn't necessarily need to be treated if it's high or low. You could treat it with vasodilators or vasopressors, but this should be based on the clinical assessment of the patient and not based on that particular number, as goes with all of these numbers. So for patients with shock, the three forms of shock, one is septic shock, one is hypovolemic shock. This I'll include hemorrhagic shock, because if you're bleeding, you're losing blood out of your intravascular space, so you have hypovolemic shock. Or you have cardiogenic shock, where your heart is not functioning based on your demands, or you have an acute heart attack or an acute heart failure, things like that. So I'm going to focus here on septic shock. But regardless of what causes your shock, it's associated with a state of hypoperfusion, organ dysfunction, and a very high risk of death. But we are going to focus on septic shock. So for your question on page 167, a self-assessment question, a 92-year-old female with urosepsis and septic shock has a past medical history of a myocardial infarction and hypertension. Her blood pressure is 72/44. Her heart rate's 120. Her creatinine is 2.7, and her urine output is 20 mils per hour. She started on empiric antibiotics. What are you going to do next? Do you want to give dopamine? Do you want to give Lasix? Do you want to give a normal saline bolus of 500 mils or albumin 5% 500 mils? Don't answer yet. So we're going to talk a little bit first. But you all know the answer already, I know. So what is sepsis? Sepsis is a systemic inflammatory reaction triggered by an infection. So your infection might start in your lung or your kidney or a cellulitis or your abdomen. But the response to that is you have a systemic inflammatory response to that infection. So even though the infection might originally have started out as a localized event, your inflammatory reaction is systemic and it has systemic ramifications. You have a release of cytokines and inflammatory mediators. Because of this causes systemic vasodilation. So your arteries and your veins are now vasodilated, which automatically means you're going to have more space and less volume. Okay, so you're going to have a volume problem. This will cause hypotension. You also have increased vascular permeability, causing fluid to shift out of the intravascular space through the capillary membranes into the interstitial space. You can have intravascular volume depletion. This leads to a reduction in cardiac function, as you all know, because you're all very familiar with the Starling curve. And this perpetuates hypotension. As you decrease your cardiac output, your blood pressure is going to drop just because of that alone. And it also perpetuates organ hypoperfusion. Organs like your kidneys, your liver, your heart, your lungs, your coagulation system. We'll talk about them. So the definitions, sepsis is defined as this systemic inflammatory response triggered by a documented or suspected infection. Severe sepsis is sepsis that's complicated by organ dysfunction or evidence of hypoperfusion. Usually it's going to be your urine output is dropped. That's evidence of organ dysfunction. Septic shock is where you have sepsis-induced hypoperfusion that responds poorly to fluid resuscitation and vasopressors. And that definition is really important. It responds poorly to fluid resuscitation and vasopressors. It's important when we start to get to corticosteroids and when should we use them or not. So hypoperfusion and organ dysfunction. This lists the organ systems and some, but not all, of the signs of dysfunction. So your cardiovascular system, how do you know if that's not functioning? You could have a low blood pressure. You could be unresponsive to fluid resuscitation. You could develop a metabolic acidosis. A metabolic acidosis develops when you have hypoperfusion, anaerobic metabolism, production of lactic acid, and an acidosis developing. Your pulmonary system, if the patient is on a ventilator. Your kidney dysfunction is evidenced by a decrease in urine output or an increase in creatinine. The first one that's going to appear is a decrease in urine output. And the creatinine is always going to kind of lag behind your kidney function, either when it improves or when it's failing. Your hematologic and coagulation systems, you could have thrombocytopenia, you could have a low white blood cell count, or an elevation in your INR. So initial resuscitation for poor perfusion, for patients with evidence of hypoperfusion, You want to complete the initial resuscitation in the first 6 hours. And when I was in Puerto Rico at the Society of Critical Care Medicine Annual Congress, there was a poster about even faster, like within 3 hours. So maybe there's going to be some evidence. I have a feeling that more evidence will come out showing 3 hours is better or 1 hour is better. Okay? The faster the better, but definitely within 6 hours. And this is where we have the most evidence currently. The goals are to optimize intravascular volume and thus optimizing your cardiac output and perfusing your organs. So the goals are a CVP of 8 to 12. If a patient's intubated, they actually have an increase in their intrathoracic pressure. So their CVP goal would be 12 to 15. It would be a little bit higher. A mean arterial pressure of 65 or higher. A urine output of at least 0.5 ml per kilogram per hour, and a venous saturation of at least 70%. These are your parameters. These are your goals. This is called early goal-directed resuscitation, and this strategy has been shown to improve mortality. And there's not many things that improve mortality in patients with sepsis. This is one of them. This is very important. This is not something that's happening in the ICU. This is happening in the emergency department. So it's worth a check. Go into your emergency department, stay there for a little bit, see how they take care of these types of patients and see how they're doing in terms of achieving these goals within the first 6 hours. So the initial resuscitation protocol calls for fluid resuscitation using crystalloids or colloids. 1,000 mils of normal saline or lactated ringers administered as fast as possible and repeat to achieve your goals. Or 300 to 500 mils of albumin, in this case they're talking about 5% albumin, administered over half an hour. There's no evidence that one strategy is superior to another. We do want to avoid head of starch. This is new in the sepsis guidelines that were just published, actually the weekend that I had to have these handouts ready for you guys. So that weekend I was combing through those guidelines. But head of starch is not recommended because it has been shown to be associated with acute kidney injury and death. You continue fluid resuscitation as long as their hemodynamic parameters are improving. You're watching their mean arterial pressure, their central venous pressure, their venous saturation, and their urine output. Patients may require aggressive fluid resuscitation in the first 24 hours. They could require a lot of fluid, 15, 20 liters and more. When do we start thinking about vasopressors? If you're unable to achieve the goals with fluids, then there's some options. The first you're going to think about is, well, what's their hemoglobin and hematocrit? If their hematocrit is less than 30%, maybe they need some blood. So you want to think about that. You could consider dobutamine to improve cardiac output as well, based on what we talked about with the the venous saturation. And you're also going to think about vasopressors. So fluid resuscitation should be achieved first, ideally. Vasopressors can be ineffective or detrimental if they're administered prior to fluid resuscitation. So getting that central line in and getting the fluids in as fast as you can is is your priority. Your priority is not to get the central line in so you can infuse your norepinephrine. It's to get your fluids going. With that said, vasopressors may be needed when hypovolemia has not been completely resolved yet in cases of life-threatening hypoperfusion. So many times you're doing it all at the same time. Your goal is to get those fluids in the fastest. But if you have life-threatening hypoperfusion, you might need vasopressors at the same time, even though you have not yet restored their intravascular volume. You're doing it at the same time, and then you're increasing the fluids still as fast as you can, and then you hopefully can titrate down on your vasopressors. Ideally, you have an arterial catheter for blood pressure measurements. It's more accurate than a blood pressure cuff for patients with shock. Think about it. Patients with shock, you're clamping down everything that's not important. So your peripheral vessels are pretty much not important. So your blood pressure cuff is not going to be a great measure of your blood pressure. Make sure your blood pressure matches the clinical scenario. and administer your vasopressors through a central line. Obviously, if they extravasate, you can have severe tissue necrosis occur. So for the vasopressors, norepinephrine is the initial vasopressor of choice to maintain your mean arterial pressure of 65 or higher. This is all based on the most current surviving sepsis guidelines, again, just published within the last month. This is a grade 1C recommendation, which means it's a strong recommendation, but it's low quality evidence. So there's not high quality evidence like grade A to recommend one vasopressor over another. The clinical practice has really been driven by expert opinion. One study, however, did find no mortality difference when comparing norepinephrine to dopamine, but there was an increased incidence of arrhythmias in patients that received dopamine, and I've referenced that article for you here. So if we focus a little bit on norepinephrine, also known as levofed, in terms of efficacy, it's a vasoconstrictor because it has potent alpha-1 induced vasoconstriction, and this maintains perfusion. In terms of safety, it can decrease your cardiac output. Think about it. It increases your afterload. This can decrease your it's harder for your heart to pump against that increased pressure. It can decrease kidney perfusion. Have to monitor for these things. It can cause peripheral ischemia if it's not titrated carefully. And it does have some beta-1 stimulation, and this can, anytime you stimulate beta-1 receptors, you can cause arrhythmias or myocardial ischemia. So any of these vasopressors that stimulate beta-1 can cause arrhythmias. Epinephrine, for some reason, has been promoted on the surviving sepsis guidelines. Not necessarily because it's now the second choice after epinephrine. So in terms of how they present it, epinephrine is second with the new guidelines, whereas before it was a little bit lower on the list. There's not anything new that's come out with epinephrine. Again, it's really expert opinion. Epinephrine also has alpha-1 induced vasoconstriction. Same thing with safety, beta-1 induced arrhythmias, myocardial ischemia. Some evidence from, this goes back to the 80s, again, reduced splanchnic circulation, so reduced perfusion of your gut, potentially causing gut ischemia. Much of this data is sort of experimental, so this is kind of the reason why I think many people avoided epinephrine for many years, but in terms of clinical evidence, there's not really any evidence that shows that it's any different than other vasopressors. It has been associated with an increase in lactate, maybe because of a hypoperfusion. So that's the reasons why it's kind of been avoided over the last couple of decades, but for whatever reason, it's kind of been promoted on the most recent guidelines in terms of where it's presented. Vasopressin has a different mechanism than the other two that I've mentioned. Vasopressin is a V1 receptor stimulation. This causes profound vasoconstriction. The V1 receptors are on your vasculature. There's some evidence that there's a relative vasopressin deficiency in patients with septic shock. So similar to patients that are hypothyroid. For patients that have shock, they have a relative vasopressin deficiency in that they're not secreting enough endogenous vasopressin for their level of blood pressure. So there's a sort of, it makes sense to administer vasopressin almost as a hormonal replacement therapy. Unfortunately, the evidence hasn't shown that it's better than other agents, though. It can be effective during patients during acidosis and hypoxia, where your alpha-1 agents are less effective. So in those patients that are kind of profoundly hypotensive and not responding well to norepinephrine or dopamine or epinephrine, it's pretty incredible to start vasopressin, and you'll see a response with their blood pressure. Again, no evidence that it improves outcomes. From a safety perspective, it's a potent vasoconstrictor. It can cause coronary and peripheral ischemia at doses greater than 0.04 units per minute. A couple decades ago, when they used to use, this is even before my time, when they used to use vasopressin for GI bleeds, they used to combine it with nitroglycerin to prevent myocardial ischemia. That's never a good thing, right? And the dose was much, much higher. This was for bleeding esophageal varices. The dose was about 10 times higher when they used it for that indication, and they combined it with nitroglycerin. That should have been a clue. Maybe it's not a good thing. It's not. Here's a risk with this. It's not titrated like traditional vasopressors. You use it. You use it at right around that 0.03 units per minute. If it works, fine. If it doesn't, you're done. You don't titrate it up. And you have definite risk in terms of vasoconstriction, myocardial ischemia, peripheral ischemia, if you do titrate it up. I also, for whatever reason, we find errors with the dosing units. ICU nurses are not used to units per minute. So there's a risk, even though I think it's easier to calculate than micrograms per kilogram per minute, they're not used to it. So there's a risk for errors with the calculations. Phenylephrine is unique in that it's an alpha-1 induced vasoconstrictor, but it doesn't, unlike epinephrine and norepinephrine, it doesn't stimulate beta-1 receptors. Because of that, you actually get a reflex slowing of your heart rate with phenylephrine. So it can be useful in those patients that are hypotensive and are having tachyarrhythmias, and you kind of want to slow their heart rate down a little bit. Phenylephrine has a nice niche for that. Again, it can decrease cardiac output. Anything that causes alpha-1 induced vasoconstriction can, and it can decrease renal perfusion. Dopamine. Dopamine has been demoted on the new sepsis guidelines, and I think that's a good thing. The efficacy of dopamine at the low dose, it's primarily a beta-1 induced inotropic effect that, actually the lower dose is more of these dopaminergic effects. This beta-1 induced inotropic effect could complement norepinephrine, which is why it was kind of combined, recommended in the previous guidelines to maybe use it with norepinephrine. You get a little bit of beta-1 from a dopamine, and that's complementary to the vasoconstrictive effect that you get from the norepinephrine. At higher doses of dopamine, though, you see primarily alpha-1 induced vasoconstriction. From a safety perspective, there's a lot of unknowns with dopamine. You first of all can have the beta-1 induced arrhythmias or myocardial ischemia, and that's been shown in evidence that dopamine has higher incidence of arrhythmias compared to norepinephrine. The unknown is with the endocrine changes. This drug can cause a decrease in prolactin, changes in growth hormone and thyroid hormone, and these can be very significant in critically ill patients, and we do not understand the clinical ramifications of this. So that's just a little bit too much unknown for my taste. The other safety issue is the inappropriate use of dopamine. I still see prescribers using dopamine, low-dose dopamine for patients with like a decrease in their urine output because of this unfounded belief that it will be renal protective. Listen, if you give a low dose of dopamine, it will increase your urine output based on your dopaminergic effect, receptors. But if you want to increase your urine output, we have safer ways to do it. So dopamine is not a good way to do that. And there is no evidence to show that dopamine is renal protective, and that's probably going on 30 years now. If we move to dobutamine, I think of this as an inodilator. It's an inotrope and a vasodilator. The inotrope is because of the beta-1 effect. So you should be thinking beta-1, okay, it can cause tachyarrhythmias. It also has beta-2 effects. And when you think of that, we think of vasodilation, okay? In the lungs, we think of bronchodilation. In the vasculature, we think of vasodilation. So patients with septic shock, you might not think of them as needing an inotrope, but they could have a relative myocardial dysfunction. And this is perhaps easiest to see if they have a low venous saturation and you can't increase it after fluid resuscitation. So dobutamine can improve cardiac output, and as it improves cardiac output, remember on the Starling curve, your blood pressure should improve, okay? But you have to monitor for arrhythmias, and it could cause hypotension, again, because of that beta-2 induced vasodilation. So you could see an improvement in blood pressure, but you could also see a drop in blood pressure with dobutamine. You have to watch it closely. So for this particular patient, sepsis, hypotensive, acute kidney injury, antibiotics, what do you want to give next? Dopamine, Lasix, normal saline bolus, or albumin? Good. I'll drink to that. For those of you home in your PJs, everybody said normal saline bolus. Okay, so look what we've covered. Now we're going to move on to antimicrobials. So for patients with sepsis, the most common sources of infection are the lung, the abdomen, the blood, and the urinary tract. So you need to get cultures. You want to assess sputum cultures or tracheal secretions, blood cultures, urine, and stool cultures if needed, depending on what you think is the suspected source. You want to give antibiotics early, but you got to get the cultures in earlier. It's extremely important. You want to get at least 2 blood cultures before you start your antibiotics. And you want to draw at least one of them percutaneously, so right from the skin, not through an IV line. For your initial empiric antibiotic therapy, you want early and appropriate empiric antibiotic therapy. This can be life-saving. It has to be given fast. It has to cover all of the organisms. You want to start your antibiotics within the first hour of recognition of sepsis. And if multiple antibiotics are given, you want to start with your broadest one first and give it as quickly as possible. Every hour of delay has been shown to be associated with worse outcomes. So this really is something we need to get done. De-escalation therapy based on cultures and the clinical scenario can occur after a few days. A typical duration is 7 to 10 days. You can use procalcitonin as a guide. This is not in your text, but it's recently been mentioned in the new sepsis guidelines. Procalcitonin has been shown to help guide in terms of appropriate duration of antibiotics, so it decreases antibiotic exposure without worsening outcomes. So the outcomes are similar, but you have less antibiotic exposure, and there's a few articles, a few studies that have shown that. You might consider empiric fungal therapy in patients that have risk factors. This would be somebody with recent abdominal surgery, chronic parenteral nutrition, indwelling central venous catheter, recent broad-spectrum antibiotics, or they're immunocompromised. Maybe they're receiving chronic corticosteroids or other immunosuppressants. They might have neutropenia. They might have a malignancy. They might have organ transplant. I will just go back for a minute to the antibiotics, and we're kind of constantly struggling with this early empiric, early broad-spectrum therapy, and then after the 2 or 3 days, when you're kind of honing in on what your site is and what your organism is, now de-escalating your therapy. And it's one thing that I have my students mention this intervention on a daily basis on rounds, saying, here's what the culture data shows, here's what the temp has been, the white count, We talked about the chest x-ray. So you go through all of the objective information that tells you how is this patient's infection doing, and you think about de-escalation. It's not just based on one thing. It's not just based on cultures or just based on white count. It's the whole clinical situation. So you want to encourage de-escalation within that 2 to 3 day time frame. And then my students are really good about, okay, today is day 7 of antibiotics. And you want to include the whole antibiotic course. So it may be day 7 of ceftriaxone, but we started broader. So you want to say it's day 10 of your comprehensive, your empiric antibiotics, so that we can really limit, we can de-escalate when it's appropriate and limit the antibiotic exposure. So we'll talk about corticosteroids and their efficacy in septic shock. So the evidence shows that hydrocortisone, 50 milligrams IV every 6 hours, this is evidence from 2002, can improve short-term mortality in patients with hypotension that is poorly responsive to fluid resuscitation and vasopressors. So they are describing, in effect, patients with septic shock. And when this came out in 2002, what happened in the critical care community is we really started kind of extrapolating that beyond those patients and using it in lots of patients with sepsis, even if they weren't poorly responsive to fluids and vasopressors. In this situation that's described here, use of hydrocortisone in this scenario is a 2C recommendation. It's a weak recommendation based on low quality evidence because the study was significantly underpowered. But again, we took that and we extrapolated it in many ICUs across the country to other less severely ill patients. Then the Corticus trial was published in 2008, and this evaluated the same regimen of hydrocortisone in patients with sepsis requiring vasopressors, but not necessarily with persistent hypotension. Okay, we met our goals while they were on their vasopressors. And this study showed there was no mortality benefit. There was an increased risk of hyperglycemia and an increased risk of new sepsis or septic shock, perhaps due to the detrimental effects of corticosteroids. So when this was published, we really had to evaluate our own use. Were we overusing corticosteroids? And I think a lot of the critical care community was until this Corticus trial was published. Fludrocortisone, 50 micrograms daily, had been removed from the 2013 guidelines. It's unnecessary in theory because hydrocortisone has mineralocorticoid activity. Also, recently substantiated a lack of benefit with fludrocortisone in a coitus study. So we used to have fludrocortisone added to hydrocortisone, but that is no longer. You do not need to assess adrenal function with ACTH or other measures such as cortisol. They're not shown to change outcomes. And once vasopressors are no longer required, you should taper off and then discontinue your corticosteroids if you were using them appropriately. So the patient case from number 4 is a 65-year-old female in the CCU for a myocardial infarction. On day 4, her blood pressure has dropped to 80/50. Her heart rate is 125, respiratory rate 30. She's hypoxic, is febrile at 102, confused, and has infiltrates on her chest X-ray. She's given a liter of normal saline ×2, intubated, and started on piperacillin, tazobactam, and ciprofloxacin for presumed nosocomial pneumonia. A further fluid bolus is ineffective in this patient. What do you want to do now? Do you want to add clindamycin to cover aspiration pneumonia? Do you want to add dobutamine, or add norepinephrine, or add hydrocortisone 50 IV every 6 hours? Let's see what you want to do. All right, I see a lot of green. And I agree with you. you really want to focus on perfusion first. So the key there was the further fluid resuscitation was not effective in improving her hemodynamics. And so this would be a good time to think about a vasopressor then and titrate to a goal mean arterial pressure of at least 65. We wouldn't need Clinda in this case because we already had Zosyn on board, and that's covering everything you need to cover. There wasn't any indication that we would need dobutamine, and you have to be careful in hypotensive patients with that. And because you want to start the vasopressors first, if she then were not responding to norepinephrine, if she were persistently hypotensive despite norepinephrine, then you could consider adding hydrocortisone. So another case from patient case 6, a 42-year-old man unresponsive with a blood pressure of 72/30. He was found covered in vomit. He was intubated, and we were ruling out aspiration pneumonia. His white count was 20, his lactic acid 15, his AST elevated at 78, a creatinine elevated at 2 with a baseline of 1, platelet count of 118,000, an INR of 1.4, and a low urine output. He's receiving 5 liters of normal saline and 5% albumin. His blood pressure, his mean arterial pressure is 66 on norepinephrine 40 mics per minute, and he started on Zosyn. What do you want to do next? Do you want to add hydrocortisone, check a random cortisol level, add low-dose dopamine, or add Lovenox, 40 milligrams sub-Q daily? Okay, like so few of you are answering. Go ahead, answer. So, put something up. Some yellow, some blue. Okay, yellow and blue. Well, I wouldn't add hydrocortisone because if we go back, the mean arterial pressure is 66. So I would say that the patient is responding to fluids and vasopressors, okay, because of that mean arterial pressure. Obviously, we talked about there's no need to check a random cortisol level, and we don't need to add low-dose dopamine because we don't believe it protects the kidneys in any way. And the patient does need DVT prophylaxis. You might think that you wouldn't give DVT prophylaxis because the INR was elevated and the platelet count was 114, so it was a little bit low. These patients still do need DVT prophylaxis. They're at an increased risk. And even though his INR is a little bit elevated, that hasn't been shown to be, he's not auto-anticoagulating himself enough to prevent a DVT. So for sepsis resuscitation, we have bundles. And all of these things, the whole package together is what we look at to improve care. It's not just looking at one individual protocol, but everything taken together. And basically these bundles include, we should measure serum lactate in these patients, which is a sign of hypoperfusion. You want to get your blood cultures before your antibiotics are in. These are all quality indicators. Timely, broad spectrum antibiotics, early goal-directed therapy within the first 6 hours, the consideration of corticosteroids and the appropriate use of corticosteroids, and glucose control, which we'll get to in a little bit. So all of it together is what we look at for sepsis in terms of improving quality and outcomes. So we've covered all of the sepsis-related topics. Now we're going to kind of go through the other critical care issues. Patient case 7, a 51-year-old female collapses. Her family called 911 and started CPR. She was unresponsive. Her heart rate was 20. In the ER, her mean arterial pressure was 68 after she received fluids and norepinephrine. A hypothermia protocol was initiated for 24 hours, and when you arrived to the ICU the next morning, they had started the rewarming process. She's receiving an insulin continuous infusion, and the AccuChecks are every 6 hours. She's getting propofol, a continuous infusion, and Nimbex, which is a neuromuscular blocker, a paralytic. So what's next? Do you want, and remember now that they're cooling her. Do you want to increase her blood glucose testing to every 1 to 2 hours? Do you want to adjust her paralytic to a train of 4 of 0 out of 4? Do you want to discontinue her propofol to facilitate extubation? Do you want to increase her insulin to prevent hyperkalemia? So we're not going to answer quite yet. We're going to talk about it a little bit first. So we're going to start by talking about hypothermia. Inducing hypothermia and the targeted temperature is 32 to 34 degrees Celsius. For 12 to 24 hours, post-cardiac arrest can improve neurologic recovery and mortality. You want to consider if you've successfully resuscitated a patient, but they remain comatose. You can achieve this using ice packs, cooling blankets, and the infusion of cold IV fluids. Patients will need sedation and analgesia during their periods of hypothermia. Even though they're comatose, they need sedation and analgesia during this time period. Okay, even though they're comatose. Complications of hypothermia, one is shivering. When you shiver, that increases your body temperature, and that's working against us. So you want to prevent the shivering with sedatives. You can use anesthetics, analgesics, opioid analgesics. You could use dexamethasone, clonidine, magnesium, ondansetron, or paralytics. Shivering is more common during the cooling process. And once they're cold, not all patients shiver. And they also don't necessarily shiver as they're warming. So you don't have to use these drugs unless you're having a problem with shivering. There's a real nice reference that I've included in your book that talks about the evidence behind all of these different agents that I've listed here. Other issues with hypothermia is you have a reduction in your drug clearance. So this can include your sedatives, your opioids, and your paralytics. You're not clearing them as fast. That's why we cool people, because it slows down their metabolic rate, and that's theoretically one of the reasons why you improve their neurologic outcomes. You can use a normal bolus dose of these drugs, but you usually are going to need to reduce your maintenance doses. And it's hard to adjust them because you can't assess the patient to them. So you have to kind of just use your best judgment as to how to dose these patients, because we're not measuring their sedation scale, we're not assessing their pain management when they're during this 12 to 24-hour hypothermia protocol. They also are going to need intravascular volume replacement, and you can replace this with crystalloids. So they're going to have fluid shifts during this time period as well. More complications. They're going to have electrolyte imbalances. You need to be proactive with this. When you're cooling them, their potassium shifts into the cell, so does magnesium and phos. So those are going to decrease. When you're rewarming them, the potassium is going to increase. So again, be proactive. They are at increased risk of infection. For their blood glucose, they can become hyperglycemic during hypothermia. But as you warm them, their blood glucose will drop. You have to be proactive with this, and you have to adjust your insulin and your monitoring proactively to prevent hypoglycemia. They can have bed sores. They're laying perfectly still on their backsides for 24 hours. You guys try to do that. It's not good. So they can develop bed sores even in a short period of time. They have impaired bowel function, so this is not the time to be feeding them with nutrition. You're going to hold off on nutrition until later. So for this particular patient, what we're going to do here is, do you want to increase her blood? Now you can answer. Do you want to increase her blood glucose testing? Remember, it was Q6. Do you want to increase it to every 1 to 2 hours? Do you want to adjust her cis-atracurium for a train of 4 of 0 out of 4? And that's, I'm not going to explain it here, but it is described in your book. Do you want to discontinue the propofol to facilitate extubation or increase her insulin to prevent hyperkalemia? And most of you are saying, number one, increase your blood glucose testing to every 1 to 2 hours, and that's absolutely right. Recognizing that she's, during the rewarming, her blood glucose is going to drop and she's getting a lot of insulin, and that's likely going to need to slow down. So you're going to you may need to even turn off. So patients that are on an insulin drip during hypothermia, they may not need it during rewarming. For your cisatracurium, for any paralytics, if they're not shivering, you can consider discontinuing them. In my previous institution, they used paralytics throughout the entire time of hypothermia, and you don't have to do that. There's no need to do that. You use your paralytics if you need to for shivering. There's other agents you can use as well. You really want to minimize use of paralytics, especially considering that with hypothermia, you have a decreased metabolism and you can have a prolonged duration from these drugs, and you can have prolonged weakness. So you want to avoid paralytics if possible when you can. You would not DC your sedatives or analgesics to facilitate extubation. You're not going to do that, especially when patients are paralyzed or during while they're cold, during the period of hypothermia. For the insulin, you're going to monitor your potassium and your blood glucose as well, and you're going to be proactive and treat it if needed. So think a little bit more about this patient. Do comatose patients who are paralyzed need to be sedated? And I already kind of mentioned that, but especially with this patient, because I was very, very upset when I got to the ICU and they were discontinuing her propofol and when she was paralyzed. And the reaction, the reason I got from very experienced clinicians was, A, she was hypotensive, and so they wanted to DC the propofol for that reason, and B, she was comatose. And these are, none of those are good reasons. They're horrible reasons. So you have to give these patients the benefit of the doubt. You're not going to be able to assess their neurologic function during the hypothermia, especially not when they're paralyzed. These patients need sedatives and they need analgesics together. And you don't stop it. And if they're hypotensive on a certain sedative, then you switch to another one. You can use, there's other sedatives and analgesics that you can use in hypotensive patients, and we'll get to those in a minute here. So here's another patient, case number 8. We're moving on to sedation now. An elderly woman was admitted for acute decompensated heart failure and acute kidney injury. She was intubated for pulmonary edema. Her RASS scale, a measure of her sedation, was 2+, which means she was agitated. Her CAM-ICU, a measure of delirium, was positive for delirium. She denies pain based on a pain scale, but I need to add that to that case. Her blood pressure was 120/70 and her heart rate was 88. Which is the best for sedation? Do you want to use propofol, Haldol, lorazepam, intermittent, or morphine, intermittent? So we'll come back to that. So the first thing, the surviving sepsis guidelines are new recently, and so are the sedation guidelines. They're recently published as well in 2013. And all of this comes from the sedation guidelines. You want to consider non-pharmacologic strategies for analgesia and sedation, and this makes sense. These non-pharmacologic strategies are right up there with food and water and shelter, right? Window light, natural lighting has been shown to improve comfort. Lighting, all those lights that they shine down on those patients, those fluorescent lights, would you just want to shoot yourself, right, if you're staring up at those lights in the ICUs? So some better lighting in ICUs. Music, based on that patient's preference, not on our preferences, but whatever music that patient likes. And patient positioning. These are all things that just we all would want if we were those ICU patients. Not all patients will require analgesics and sedatives. Some will require nothing. You want to assess and treat pain first and then sedation. So it's an analgeo-sedation approach. Self-reporting is preferred over pain scales in patients who can communicate. So this is for pain. For pain management, if patients can self-report their pain, that's preferred. If they're unable to self-report their pain, then there are several scales that have been validated to show that they're a validated assessment of pain. I've listed two here. There are many in the guidelines that are listed, but these are the two with the highest validity scores and inter-rater reliability scores. One is the behavioral pain scale, and one is the critical care pain observation tool. These have been around for a while, but this is the first time they've made it into the sedation guidelines. And I've got both of these in your book for you to see. Vital signs are cues that maybe somebody's in pain, like a hypertension, an increase in blood pressure or heart rate, but they're not absolute. So these tools above are better. So this is an example of the behavioral pain scale, which I put up here only because I could fit it easily on a slide, and the other one is a little bit more in depth. But the CPOT scale actually has a little bit higher validity and reliability rating numbers. But this one, they're similar in that they look at facial expression of these patients. So again, these are patients that can't say, yes, I have pain. They can't say that. They can't communicate that. Their facial expression, whether it's relaxed or tightened or they're grimacing, their upper limb movement. Are they bending their arms? Are they permanently retracted? And their compliance with the mechanical ventilation. Are they tolerating it? Are they coughing a little bit? Are they fighting the ventilator? Are you unable to control their ventilation? So you give them a score, and the score ranges from 3 to 12. Now, for both of these scales that are in your book, it's kind of a yes or no thing. It's not a rating like my pain is a 10 out of 10 or a 5 out of 10. It's yes, they have pain, or no, they don't. So for this particular one, if they score a 6 or higher, then it's an indication that they have pain. It doesn't speak to their degree of pain. It's just, do they have pain, yes or no? And it's the same thing with the CPOT. So it's important that we don't extrapolate that to, the degree of pain. You want to assess sedation as well. So you would assess their pain first, and you also assess sedation now with a tool that's valid and reliable for adult ICU patients. Most commonly, that's the RASS or the SAS scale is what's most commonly used. And we're pretty familiar with using this, but we're not so familiar with assessing analgesia first and in addition to this. So for the approach to analgesia and sedation, you treat the pain first and you add a sedative if needed. Opioids have analgesic and sedative properties, so you could treat analgesia and sedation with opioids. You want to use analgesics before potentially painful procedures. Makes sense. Opioids are the first drug of choice for pain management. The non-opioids and opioid analgesics can be used in combination to improve efficacy and safety. An example would be Tylenol. You can use Tylenol regularly. Ideally, you would use it enterally and every 6 hours to have an opioid-sparing effect. I avoid, and most critical care practitioners avoid nonsteroidals because of the risk of bleeding and also the risk of acute kidney injury. Non-benzodiazepine sedatives are preferred because benzodiazepines have been associated with an increased risk of delirium, and we'll get to that in a little bit. So non-benzo sedatives are preferred over benzodiazepines. So for dosing, your goal is you want patients to be comfortable, but you do not want them over-sedated. Light sedation is needed for evaluating their pain and their delirium, and for early mobility, which has been shown to be associated with improved outcomes and improvement in patient comfort. You can try intermittent dosing routinely. You can give drugs routinely every 4 hours, every 6 hours, around the clock. You could give them PRN as well. It's going to depend on your patient. You could give a continuous infusion. My point is, not everybody needs a continuous infusion. You might be okay with one intermittent, one continuous infusion, or just a little PRN in some patients. For a continuous infusion, there's a few things that you need to think about. You want to use a bolus dose before or instead of increasing the rate for opioids and benzodiazepines, assuming their blood pressure tolerates. Some of these drugs, their blood pressure drops with bolus doses, so you can't use them. But you want to try to use a bolus dose. Just increasing the rate is going to have a slow onset. You want to use your bolus dosing proactively, such as for dressing changes or any kind of painful procedure. And think about a hybrid approach where you have an intermittent drug 1 combined with a continuous infusion of drug 2. You want to have a protocol that incorporates certain parameters. These protocols for analgesia and sedation should have a regular reduction in your infusion rates. Okay, we should have a prompt to reduce the rate of the infusion. You want to have a daily interruption, and this has benefits because you can assess the patient's neurologic function. You can reevaluate, well, what's the lowest dose that I need in this patient? Because a lot of these patients have metabolic changes and maybe they don't need the dose that they're getting. You can prevent drug accumulation and prevent overdose, and you can reduce the duration of mechanical ventilation and the ICU length of stay. This is not in the text, but recently in JAMA, daily interruption has shown not to be beneficial. So I'm just putting this in here to show you that the data is conflicting in terms of whether daily interruption has benefits or not, but it is something that we've been doing traditionally. Laxatives and stool softeners should be used proactively in patients receiving opioids. If they're getting an opioid, it should be a knee-jerk response to start laxatives and stool softeners. And this can dramatically improve patient comfort. So the reality of analgesia and sedation is that infusion rates get increased but not decreased unless we're specifically during ventilator weaning. Protocols need to specify the times for rate reductions. And bolus dosing is underused during continuous infusions of opioids and benzodiazepines. It has a faster onset than increasing the infusion rate, and it can eliminate your need for an infusion rate. Maybe you just give them a little bolus, you get through this time period, you don't need to increase their infusion rate. It's not necessary, you don't need to bolus dose with the very short-acting sedatives like propofol or dexmedetomidine, because these drugs can have hypotension or bradycardia with bolus dosing. So for the opioid analgesics, this is kind of summarizing the different agents. For morphine, the problem with that is this histamine release. The histamine release can cause hypotension, it can cause itching and a rash. It's not necessary that the patient's allergic to it, but it's causing histamine release, which mimics an allergic reaction. Either way, it can be uncomfortable. It also has active metabolites that are renally eliminated. So in patients with kidney injury, which can be common in patients with organ hypoperfusion, sepsis, you have to be careful with it can be unpredictable because of these active metabolites that are renally eliminated. Hydromorphone is one downside of it is the dosing errors. 2 milligrams of hydromorphone is a ton of hydromorphone. And so people think of it in terms of morphine dosing. And I've seen 18-year-old boys given 2 milligrams of hydromorphone that had to be intubated and transferred to the ICU. Okay? So we have errors with it. little old ladies and elderly patients, a 0.5 milligram of hydromorphone should be fine. I try to avoid doses greater than 1.5 milligrams. It's nice if you can get the dose right because it has no active metabolites, so it's a cleaner drug than morphine. Fentanyl is nice because it does not cause histamine release, so you can use it in patients that have the pseudo-allergic reaction, or if they're having hypotension because of morphine, you should not have that with fentanyl. It's useful in hypotensive patients. It's short-acting with single intermittent doses, but if you give it as a continuous infusion, it behaves more as a longer-acting drug because of accumulation. And it can have an increased duration in obese patients because of the distribution in those patients. Remifentanil, really nice, really short-acting, very expensive, so limited because of that. For the benzodiazepines, lorazepam is in intermittent doses of it. It's actually a pretty decent sedative, and it's predictable even if patients have kidney and liver disease. The metabolic pathways are preserved, except with like the end-stage liver disease. So even with mild liver and kidney disease, this drug is pretty predictable. It is mixed in propylene glycol, which limits it at high doses. You can get propylene glycol toxicity. For midazolam, there are changes in drug metabolism during critical illness that make this drug, can make it a little bit less predictable in some patients. You have to monitor it. It emphasizes the importance of dosing it based on the patient's sedation scale. So you need to have an objective measure of how to dose it. There are some drug interactions with midazolam, and it does have active metabolites. Again, the benzodiazepines are associated with delirium. Propofol is probably one of the most commonly used sedatives. It's very rapid onset. It has a short duration within minutes. Even many times after prolonged use, the duration is relatively short. It can cause hypotension, primarily with bolus dosing. It can cause respiratory depression, so you use it in intubated patients, which is what Michael Jackson found out. An important thing about propofol is there is no significant analgesic effect. Your patients will be sedated. You are not giving them any analgesia with propofol. And they may not be able to tell you that they're in pain, so you have to really be thinking about it. It's mixed in a 10% lipid emulsion. It's usually not a big deal for typical rates of propofol, but it can add up with higher rates, so you should consider the calories. It provides about 1.1 calorie per mil, so for higher rates of propofol, this can add up in terms of calories, and you could be overfeeding your patient if you're also giving them tube feedings or other forms of nutrition. You want to monitor your triglyceride count periodically to make sure that it's not elevated. And propofol infusion syndrome, I start to get nervous with propofol whenever we are at prolonged doses in the range of 50 mics per kilo per minute for a prolonged period of time. Whenever we get to that dose range of 50 mics per kilo per minute, I start to recommend adding an additional sedative or analgesic underneath it in order to decrease the propofol to a safer infusion rate. Some signs and symptoms of propofol infusion syndrome are metabolic acidosis. You can have cardiac failure with arrhythmias, cardiac arrest, rhabdomyolysis, hyperkalemia, kidney failure, and with prolonged high doses of propofol, I already mentioned this, I recommend a second agent in order to bring the rate down. So benzos versus propofol. Benzodiazepines have a longer duration, definitely, compared to propofol. They're not as titratable, they're not as predictable. Some patients will require really large amounts of benzos to achieve their sedation goals, and you can actually have a paradoxical agitation in some patients with benzos. So if you're going up and up and up on that dose, it's probably time to switch to a different agent. They're also associated with delirium. So now we'll talk about dexmedetomidine, or Precedex. This has sedative and analgesic activity mediated through the central and peripheral alpha-2 receptor stimulation, but the extent of this analgesic activity is really not well described, and if you look at surgical patients postoperatively, most of them will need additional pain medications. So it has some analgesic activity, but it doesn't mean that it treats your pain. It does not have respiratory depression, and that's really a nice factor with it. It is titratable, it has a rapid onset and a short duration. It can cause bradycardia and hypotension, especially with bolus dosing, so you want to avoid that if possible. It's FDA approved for a maximum of 24 hours, but evidence of safety and efficacy is accumulating for longer infusions, and almost nobody I know pays any attention to this 24-hour limit. It's associated with a reduced incidence of delirium when compared to benzodiazepines. I feel like this advertisement about less incidence of delirium is being extrapolated to other sedatives, and let me be clear, it's when compared to benzodiazepines. So we need evidence comparing dexmedetomidine to propofol, but there isn't any well-controlled evidence that shows that dexmedetomidine has decreased delirium compared to propofol. Okay, so I think it's important to make that distinction. So for this particular patient, let's assume that the patient does not have pain. And how do you want to treat them? I need to fix this case because to really say that they don't have pain, you can't just say they deny pain. You need to assess it, because if the patient is agitated or they have delirium, you may not really be able to assess that appropriately. So for this patient, I would definitely use the pain scales for that. So a lot of people are saying blue for propofol, and I would agree with that. I would definitely assess pain, and if there is pain, an opioid would be another option. I wouldn't use Haldol because even though the patient is showing positive for delirium, there are so many non-pharmacologic strategies for delirium that I would try those first. Because they have delirium, you would avoid lorazepam or any benzodiazepine. So moving on to delirium, it's defined as an acute change in cognitive function characterized by disorganized thought, altered level of consciousness, and inattentiveness. It's associated with an increase in mortality and an increase in length of stay. That doesn't mean that it causes an increase in mortality or causes a length of stay. It means it travels together, okay? That patients with delirium tend to have a higher mortality and length of stay. You want to use a validated tool to identify delirium and assess it. I've given you a couple here, the CAM ICU or the intensive care delirium screening checklist. Treatment, again, non-pharmacologic, verbal reassurance, uninterrupted sleep, natural lighting, early mobility, like really common sense things. Put pictures of their family members in their room, whatever you need to do. Avoid benzos, avoid anticholinergics. You can use Haldol if you need to. Here's a dose. I usually start with 1 to 10 milligrams. I'll double it every 20 minutes until you find the dose that works. Once the patient is calm, I'll give the total amount of Haldol that it took to calm them down, and I'll divide it up into 4 daily doses given every 6 hours, okay? You can monitor blood pressure. You gotta check QT at your baseline before you start using haloperidol. Make sure that they don't have a prolonged QT interval. Look for drug interactions. Quinolones, macrolides, can prolong QT, so you have to be very careful about that. Look for extrapyramidal side effects like laryngeal dystonia and dysphagia and seizures. Atypical antipsychotic or alternatives, there's very little evidence in critically ill patients. Basically, non-pharmacologic treatment is really where the money is for delirium. And there's no money in it. Okay, hyperglycemia. So like I said at the beginning, we've kind of come full circle. Before 2001, before this paper was published by Greet Vandenberg in 2001, we pretty much were like, oh, as long as the blood glucose is less than 200, we're good to go. And then in 2001, Greet Vandenberg published this really cool paper in the New England Journal of Medicine showing that tight blood glucose control to 80 to 110 in critically ill patients reduced mortality. It's pretty amazing that for the short period of time, tight blood glucose control improves mortality. It was a single-center study, primarily cardiac surgery patients, and the incidence of hypoglycemia in the tight group was 5% versus 0.8% in the other group. The other group was keep them less than 180, okay? Between 2002 and 2008, most of the ICUs around the country adopted intensive insulin protocols. Everybody was talking about it. It was a big news. Also between that time frame, people were trying to reproduce her results, and they weren't able to do that. We were having trouble reproducing it in other ICUs, in other patient populations. Dr. Vandenberg herself in 2006 did a study in medical intensive care unit patients, again, showing tight blood glucose control. But in that study, she showed an incidence of hypoglycemia of 18% in the tight blood glucose control. And during this time, a lot of people were saying, I'm seeing a lot of hypoglycemia. Is that bad? How much is okay? How bad is it? What are the outcomes associated with hypoglycemia? A lot of unanswered questions. In 2007, the Society of Critical Care Medicine kind of hedged their bets and said, okay, we're not really sure, just keep the blood glucose less than 150. In 2009, we had the publication of the NICE sugar study, which was in over 6,000 medical and surgical ICU patients, comparing tight control 80 to 108 versus less than 180. They showed an increase in mortality. 27.5% versus 24.9%, statistically significant. The risk of hypoglycemia was also increased. It was defined as a blood glucose less than 40, 6.8% in the tight group versus 0.5% in the other group. So this stopped that madness in its tracks. And so now the guidelines were kind of back to the 2000 time frame where keep them less than 200, less than 180. So the new guidelines recommend a target of less than 180. Many suggest 140 to 180. We don't know the exact range. Regardless of the range, glucose control is important in all critically ill patients, not just patients with diabetes and critical illness, in non-diabetic patients as well. You also want to be careful that your point of care testing that you can do at the bedside, the capillary blood or the finger sticks, can overestimate your plasma glucose values. So be careful with how you're measuring it. Moving forward, you want to avoid, when we're trying to prevent hyperglycemia, you want to avoid sole therapy with the insulin sliding scales. The sliding scale is reactionary. It's like, let it get high and then treat it. Let it get high and then treat it. You don't want to do that. You want to consider a baseline of insulin. It's hard to think about this in non-diabetic patients, but they might need a baseline of insulin. Like Lantus, you could choose NPH. You could choose regular insulin, give it every 6 hours. It doesn't matter which one you choose. But give them a baseline, and then you want to adjust it daily based on your sliding scale. So if you're giving your baseline, but you're still needing a sliding scale, you can take that sliding scale and add it to your baseline and try to keep them less than 180. Patients may require IV insulin because of variable subcutaneous absorption. An insulin protocol adjustments should take into consideration, well, what's the blood glucose value? What was the rate of change? Is it moving quickly? And what's your current insulin infusion rate? So we're almost there. Next is stress ulcer prophylaxis. So a 73-year-old female, after a cardiac arrest, intubated, her vitals are stable, She's got an oral gastric feeding tube, and she's getting fed with tube feedings. She's on amiodarone, simvastatin, clopidogrel, aspirin, metoprolol, heparin, normal saline. Which is best now? Do you want to give her famotidine through the feeding tube, esomeprazole through the feeding tube, sucralfate through the feeding tube, or ranitidine IV? You're saying blue, and I forget which one is blue. Let's see. Oh, I'll come back to it. All right, we'll come back to it. 2 major risk factors for stress ulcer. I must say this every single month. I'm going to tattoo it to my forehead, okay? Because every month when the residents change in the ICU, they all need to hear it. There's 2 major risk factors for a stress ulcer. There's other risk factors, I know, but these are the 2 major ones. Respiratory failure requiring mechanical ventilation, that's 1. Okay, if they're on that BiPAP, I'll count that, okay, because they're right on the edge, okay? So even if it's BiPAP, non-invasive, that's right on the edge. I'll count that. And a coagulopathy. What does that mean? At this point, I usually quiz my students what it means, but I can't quiz 500 people. So a coagulopathy means a platelet count that's low, less than 50,000, an elevated INR, greater than 1.5, not because of Coumadin, but because your liver isn't producing your clotting factors. An APTT that's greater than 2 times your control. Note that prophylactic or treatment doses of anticoagulants does not mean you have a coagulopathy, okay? So for stress ulcer prophylaxis, what can you give? You can give H2 blockers. There's more evidence with H2 blockers. You can also give proton pump inhibitors. There's less evidence with them in terms of stress ulcer prophylaxis. We have more evidence with proton pump inhibitors with GI bleeds, but not so much with stress ulcer. There's evidence demonstrating efficacy. Most of the evidence used IV administration of H2 antagonists. However, most of us give them enterally. They have a very good bioavailability, and it's very common. We typically remember to start stress ulcer prophylaxis, but we're really lousy with stopping it. We're doing horribly with that. And you do have an increased risk of Clostridium difficile infection, hospital-acquired pneumonia, and community-acquired pneumonia if they're discharged on a proton pump inhibitor with increasing gastric pH. Our stomach pH should be acidic. It's the way God made us, if you believe in that, and we shouldn't mess with it if we don't have to. So for this particular patient, most of you had blue, which was the famotidine, and I would agree with famotidine through the enteral feeding tube. I would avoid the esomeprazole because of the drug interaction with clopidogrel. I know that there's evidence that questions the clinical significance of this drug interaction, but I would still avoid it if you can. Sucralfate, H2 receptor antagonists are more effective than sucralfate, and I would avoid IV drugs when possible, as most of you would as well. So now the patient is extubated, their vitals are stable, they have a poor appetite. What are you going to do? Do you want to continue until they're discharged from the ICU? Do you want to stop it now, stress ulcer prophylaxis? Do you want to continue it until they're eating? Or do you want to DC it when they're discharged from the hospital? What do you want to do? Let's see it. I only see one person holding up a green card. Okay, now I see 3 people. Oh, green, red, red. I see a total of 6 people. Maybe it's because it's like we have 6 minutes left and you guys are already ready to be done. That's probably what it is. Well, I would DC it now. Just do it. There's no evidence that you need to continue it until they're eating, okay? Not eating is not a risk factor for a stress ulcer. So just discontinue it. Okay. Venous thromboembolism. We know that low molecular weight heparin is superior to unfractionated heparin in trauma patients or patients with spinal cord injury. They tend to be equivalent in medical patients. For unfractionated heparin, you can give it Q8 or Q12. This should really be based on the patient's risk of thrombosis versus their risk of bleeding. If they're not at an increased risk of bleeding, I would not hesitate, and I usually recommend to use it Q8 hours. If they are at an increased risk of bleeding and we're kind of on the fence about it, I would decrease it if you're nervous about it. Low molecular weight heparin is suggested in very high-risk medical patients. This is grade 2C, not because the evidence supports this, but because low molecular weight heparin has been shown to be superior to unfractionated heparin in other high-risk patients, like patients with major trauma or spinal cord injury. So what about patients with kidney dysfunction and obesity? So in patients with chronic kidney disease, there's a reference here from this. For patients with a creatinine clearance less than or between 20 and 30, you're going to reduce your dose of Lovenox to 30 milligrams a day rather than 40 a day for prophylaxis. No apparent adjustment for dalteparin or tinzaparin for short-term use. Just note that there's lots of opportunity for errors for dosing anticoagulants. People get confused with treatment doses versus prophylaxis doses. And then when you throw in kidney injury and obesity, it complicates matters. So lots of opportunity for medication errors with anticoagulants in critically ill patients. If their creatinine clearance is less than 20 or they're on dialysis, then very limited dosing for low molecular weight heparins for prophylaxis and treatment, you should consider unfractionated heparin. Anti-10A monitoring may not be reliable in patients who are dialysis patients. Okay, so this is prevention and some treatment for obese patients. I'll point out that this is expert opinion. This is not evidence-based. You want to consider increasing your low molecular weight heparin prophylaxis doses by 30% in patients of a BMI greater than 40. There's no consensus, but they suggest a peak anti-10A of 0.2 to 0.4 for prophylaxis. For treatment, I threw this in here because many patients in the ICU are obese. You want to use total body weight for low molecular weight heparin. This is not in the text, but it is referenced in this paper. You want to avoid once-a-day dosing of enoxaparin in obese patients. You don't need anti-10A if they're less than 190 kilograms, and there's a suggestion for your peak anti-10A range. But again, it's expert opinion. Moving on, I have 3 minutes left, so I'm going to kind of fly through the rest. Preventing ventilator-associated pneumonia. First thing, analgesia and sedation, daily interruption, using your validated scores to assess analgesia and sedation, and daily assessment to readiness for weaning. Keep their head of bed up. Daily oral care with chlorhexidine, and avoiding gastric over-distension. This is not proven, but pro-motility agents can do this. You want to prevent opioid-induced constipation and assess their tolerance to tube feedings on a daily basis. For nutrition support in critically ill patients, enteral nutrition improves outcomes in terms of reducing post-operative infections and improved wound healing. Interestingly, for parenteral nutrition, describes a paper recently published. When parenteral nutrition was supplemented with enteral nutrition, late initiation of parenteral nutrition, so late initiation meaning after 1 week, it had a reduction in length of stay, infection, cholestasis, and cough compared to early initiation, which was within 48 hours. These benefits were evident even in patients that could not get enteral nutrition. So no nutrition for a week was better than early parenteral nutrition. Just saying. For preventing aspiration, monitor your gastric residuals. You can hold them if it's greater than 250 to 500, your head of the bed. Feeding post-pyloric. You can use metoclopramide and erythromycin. This has been shown to decrease gastric residuals and improving tolerance, but it has not been shown in preventing aspiration pneumonia. Studies have not shown that. Caloric goals. I wish I could tell you what they are, but I can't. A recent study showed that trickle or trophic feeds, which enteral feeds in the range of 10 to 30 mils per hour, just trickling them in, provided about 16% of caloric goals, had similar outcomes, time on the vent, time in the ICU, but reduced gastric residual volume, with similar outcomes. Alternatively, caloric deficits have been associated with longer time on the vent, pressure ulcers, increased length of stay, and mortality. I can't tell you whether we should underfeed or give more calories. You can find evidence to support both. Predicting calories in critically ill. Indirect calorimetry is the gold standard for critically ill, but it's expensive and it requires expertise for the equipment. There is a reference in your handout and on this slide for predictive equations for energy needs in critically ill, and they evaluated several different equations. The Harris-Benedict equation is not recommended in this paper. The ACCP recommendation of 25 calories per kilogram per day is also not recommended. Underfeeding is associated with prolonged ventilator dependence and length of stay. And what they found was the Penn State 2003 equation, which is here, it's not in your book, but this is a great article, was the best predictor of calories in critically ill patients. This equation uses the Harris-Benedict equation plus their temperature plus their minute volume that you would get from their ventilator settings. That's it, we did it. Critical care in 90 minutes. Thank you.